Welcome to T's Voices, telling the stories of the people in our NHS community.
Today we are honoured to have our podiatric surgery team.
Hi, I'm Holly from the podiatric surgery team and I'm with my colleague Lesley.
Hi, I'm Lesley. I'm one of the consultant podiatric surgeons.
So, podiatric surgery. Now, recently we had a chat with our podiatry team, and I'm really interested to know what's the difference between you guys professionally?
Okay, so podiatry and podiatric surgery is the study of the foot. Podiatrists mainly provide non-surgical treatments of the foot, so be that in the diabetic foot, be that MSK, be that nail surgery, routine care. Podiatric surgery is surgery within the foot. All right, so problems affecting bones, joints, soft tissue. It's really important at this point to mention that podiatric surgeons are not medical doctors. They are podiatrists with extensive training in medicine and surgery of the foot.
In short, it's probably easy to say that podiatric surgery is one of the subspecialties of podiatry.
That's fascinating, isn't it?
I have to admit, that is. So, do you guys start as podiatrists and then you extend your training into this arena?
Yeah, absolutely. So there's a recognised training pathway that was developed by the Royal College of Podiatry. We all start out as undergraduate podiatrists, first and foremost. So we do our 3-year undergraduate degree. We then get into an NHS post or a private practice post, try and get some experience. And then we start to undertake our further training, which is what Holly is hoping to do very shortly. So the next stage for Holly, do you want to talk about this?
So the next stage for me, I'll just give you a little bit of background. When I qualified as a podiatrist, I moved to Asia. I worked as a podiatrist for 3 years. I then came back to the NHS. I've worked for a neighbouring trust for the last 10 years. Obviously, you work in MDT teams, you'll know yourself, and I worked with a lot of orthopaedic, vascular surgeons, and I was just absolutely fascinated by the surgical side of things. And I thought, this is something I'd really love to do. And a few years ago, I reached out to the team at the One Life, North Tees and Hartlepool, and sort of went on a shadowing experience, absolutely loved it, and I just knew from then what I wanted to do. For the last 2 years, as well as working full-time, it's nearly killed us, I have studied the theory of podiatric surgery. So that's a 2-year course at the University of Huddersfield. After that, the next step is that you try and look for what we call a trust to become affiliated with, so you can potentially get a training post for them. And I'm quite new, so within this last few months, that's what I've been doing, and I've been successful to get a post.
Well done.
After that, what comes is the Master of Podiatric Surgery, so that's a 3-year course. After this, I know it takes a long time.
Wow.
Following this, then you become a reg.
So you've got the MSc theory, which Holly has already done. So she's already got 1 master's degree under her belt. The next step will be a second master programme at the University of Huddersfield while she's doing her theory and her practical skills in becoming a trainee surgeon. She'll then complete that master programme, and then when she's successful with that, she can apply for a registrar position. The registrar posts are where you're really trying to cement your practical skills, try and get your advanced surgical skills starting to be developed and increase your experience. They last usually between 3 and 5 years. You then submit a portfolio. At the end of that, you have a logbook and a portfolio that you have to meet a minimum numbers requirement to make sure that you can demonstrate that you are safe, competent, well-rounded and experienced enough to be a podiatric surgeon. At the end of all of that, you can then apply for a consultant podiatric surgery post when one becomes available. So that's where I've just been successful in my appointment within the last 12 months. So from start to finish, it is about 10 years of training if you include the undergraduate training as well, or 7 years of post-registration experience as a minimum.
Wow, so a lot of dedication.
Absolutely, yes.
And I think people listening to this podcast won't realise that this is a career path for podiatrists or AHPs. And it's a lot of hard work, but now you're in that position, how does it feel now you can do that and you have access to those surgeries and things like that to do your clinics?
It's incredible, really, to think that as an AHP, I am able to offer a surgical long-term solution to patients. And that is something that's really driven me as an individual to become a podiatric surgeon. I wanted to be able to have a solution that I could make somebody's quality of life better. And I think feet are very much an overlooked part of us. We take them for granted until they hurt. And quite often when they do hurt, there isn't a lot to see. So people don't get a lot of sympathy from their friends and family either. But when they have problems, they know about it. And to be able to have options, both non-surgical and surgical, for patients, I think is incredible. And I'm really proud to be an AHP and think about not just about my surgical skills, but in my surgical training, what other skills have I developed that I can share with my colleagues, with other service users. So as part of that, I'm an independent prescriber. Our team, we're really lucky in podiatric surgery. You do not have to be a surgeon to work in the field of podiatric surgery. So we have a team of healthcare assistants, nurses, and staff podiatrists and principal podiatrists as well. That is where Holly's currently sitting, is she, while I'm doing the surgery, Holly is facilitating me doing the surgery because she's making sure that the patients are numb when they come through for theatre. Do you want to talk a little bit about your day, Holly, and what you would normally be doing?
Day to day, we do an array of different things. We assess patients, obviously. We do listing appointments. So a listing appointment is basically when a patient comes in, we decide on a surgery together. I don't do them on my own, but that's a great learning opportunity for me because I work alongside a surgeon and they teach me in that moment. So that's great. A theatre day sort of looks like we'll bring the patients in, we'll check all medication, and as a podiatrist on our ward, it's our responsibility to make sure that theatre session runs smoothly. Like Lesley says, we facilitate the anaesthetic block, so that could be an ankle block or a popliteal block behind the knee. Once the patient's numb, then obviously they would go into surgery and it allows Lesley to be able to operate on that patient. Lesley will do a surgical procedure, the patient will come out, and then we will facilitate any discharge along with the aid of the nurses and healthcare assistants. That for us may be discharging with medication, talking over how a patient's journey over the next few weeks will look, explaining how they'll mobilise over the next few weeks, and then when they come back and see us, we also would oversee redressing clinics, just making sure everything was all right, flagging anything to surgeons if there was any problems.
So as an ODP, I obviously have worked with our orthopaedic surgeons. Where do you sit when it comes to working alongside other surgeons and other surgeries?
So it's really important that because we are based out in the community, we do link in with other teams and other specialties. We undertake the preoperative assessments in our department. They don't go to a central preoperative assessment hub. So we need to have that knowledge and that ability to make those decisions about how to keep those patients safe. But we work very closely with other departments. So we will liaise with microbiology, with haematology, with rheumatology, quite frequently in how we manage those patients best and their medications around surgery. But we have a very good working relationship with orthopaedics. We work in collaboration with orthopaedics. We're not there to replace orthopaedics, but we do bring the benefit of being a community service. All of our services are done outside of the main secondary care hospital. It's done as a day case elective surgery. Patients are awake for their operation, but they're back home usually by lunchtime or by tea time. And that means that the orthopaedic surgeons have the abilities or less pressures on their time to be able to do the focus on the areas that they need to be able to focus on, while also reducing bed stays for secondary care, reducing impact on secondary care theatres, when it can be done safely in an ambulatory setting in community. So I think that's the big difference. But we do work very closely with them. We do have meetings with them. We share cases. We might refer to them for a second opinion, but they also will refer patients to us as well. So we do try and work together as much as we can, because that is going to ultimately benefit our patient population.
So you have like a setup in a community area where you do things like consent and things like that, all independently away, and take that pressure off them areas.
Absolutely, yeah, we do everything in-house. We're very self-reliant really in that sense, but I think that's what gives such job satisfaction. It's the variety that you can get on the day. Holly said you can be doing new patient assessments, redressings, pre-operative assessments in the morning, and then you could be in theatre in the afternoon performing the advanced anaesthetics to make sure that the patients are numb and comfortable for their surgery. But we couldn't do any of that without the wider team, with the healthcare assistants and the nurses as well. And I'm really proud to work in the team that we do. We have a very high performing team, and we get a lot of positive patient feedback, to the point that we are frequently in the top 5 in the monthly roundups that are sent out, which for a small team I think is something that we should shout about.
Definitely. Yeah, absolutely. Just before we finish the podcast, I'm just interested, we were talking a little bit before about some of the projects you've been working on and where that you've been facilitating other things. Did you want to talk a little bit about that and then have some final thoughts?
Yeah. Do you want to take the consent question?
So consent is one of the projects we've been working on, and it's known as consent rictus. It just shortens it a little bit. Basically, this started in 2021, so before I actually joined the team, but it's been a huge piece of work. We are the first team to implement digital consent. So all of a patient record, as you probably know, everything except most consent forms, which is on paper, we've implemented actually a way of signing the consent. So what happens is a patient receives an SMS or an email. It comes to their mobile phone or email address, and after that they decide it can be done in clinic or it can be done remotely. What's attached to that is lots of information about what surgery they're having. Most importantly for us, it explains the benefits and risks in layman's terms. It gives you percentages of the chances and likelihood of something happening, which I think for Lesley, especially as a surgeon, is crucial for people to understand, because I think sometimes people just come in and think, oh, I'm having a surgery, and they don't understand risk that comes with that. So that's really, really important. We are looking hopefully to roll that out to the rest of the trust, and I think there's a business case gone through for that.
So we have acted as the pilot really. So because we're the first department within the trust to have used digital consent, and it's proven to be really beneficial for us. It gives a much more robust, informed consent process, because it doesn't replace that conversation. I do want to make that clear. We do still have the conversation and the consent discussions with patients, but this allows them to go home, sit in their own environment, talk it through with their friends, their family, have a look at it, have the infographic. So if I said it happens in 1 in 100 people, that might mean something to some people and not others. But if they can see a visual diagram of one person coloured in out of 100, it does help understand, and it does help resonate with them. So it's been a really positive impact for our service, and so it was the only part of our system that was not digital. So we've been with the pilot, and hopefully the plan is that the digital working group for University Hospital Tees will be using our pilot to inform their future work to get it rolled out elsewhere for other departments.
Really leading the way, which is what I love to see. Of AHPs and podiatrists just, pushing that boundary and just, finding a solution for things is fantastic.
I could genuinely chat all day long, and I would love to invite you back for a second podcast, because I think there's more to talk about here. Thank you so much for your time. It's been an absolute pleasure to listen to what you're doing. I'm fascinated by it.
Take care of yourselves.
And each other.
Thank you very much.
Thank you for joining us. Till next time, you've been listening to Tees Voices.